My name is Julie Urames, and I'm back with another exciting episode of Take One Patient Podcast. The reason that we're doing these communication conversations is Medical Memory, who sponsors this podcast. We have recorded over 157,000 patient visits. And we want to be able to equip doctors and nurses with the tools to not only effectively communicate with patients, but feel comfortable recording this content that they can continue to share with people that are really, really needing to better understand their care. I'm very excited today to be talking with my very good friend, Dr. Roy. He's here from the University of Texas, pediatric surgeon. Why don't you kind of introduce yourself and your experience a little bit first, and we'll kind of dive in there.
Absolutely. Well, good morning, Julie. Thank you for having me on this podcast. I'm honored to be here. Thank you to all who are joining and to tune in. I hope I can provide some useful information. So my name is Soham Roy. I am a pediatric ear, nose, and throat surgeon. I'm the chief of pediatric ear, nose, and throat surgery here at the University of Texas at Houston, and the service line director for pediatric ear, nose, and throat services for Memorial Hermann Healthcare Systems, which is one of the largest healthcare systems in the South. I also hold a number of other leadership and administrative roles. Happy to discuss those further at some point. But here I am. Thanks for having me. It's good to be here.
Yes, absolutely. So I think one of the really interesting things that I'm excited to talk about with you today is how the dynamics of the patient-doctor relationship changes and shifts when your patient is a child. And then whether there's also a third element of the parents, of course, or grandparents involved in that communication strategy. So why don't you tell me originally kind of like what made you first dive more into pediatrics versus an adult population as far as choosing who you were going to be serving?
You know, it's a great question. So when I look back at my own history, for example, I think I knew early on that I wanted to work with children. As it turns out that there are certain types of people who are sort of drawn to helping kids. Frequently, as in my case, it's because you just don't blame children for the things that happen to them, whereas sometimes the things that happen to adults kind of brought upon themselves. For me, I enjoyed working with the families and the family dynamic. And so I spent a lot of my early medical school career trying to figure out what I wanted to do. And everything that I got involved in came back to some sort of pediatric care, be it heart surgery in children, ear, nose, and throat surgery in children, and things like that. Ultimately, I settled on ear, nose, and throat surgery because it was the best fit for me. It was been a great career choice for me. But I knew even going into my training relatively early on that I thought I would ultimately pursue a career in pediatric ear, nose, and throat surgery, and that's exactly what I've done. And it's a great experience. It is a completely different dynamic than dealing with adults who can make their own decisions when you're helping to assist a family in their decision-making process. And I say family because, as you alluded to, in this era in particular, pediatric care is not just about a child. It's sometimes not just about a child and their biological parents, but there are often other influences involved, including grandparents, foster parents, other family members. It's a very different dynamic. And so you learn how to communicate not only with the child, but with their guardians and caregivers as well.
Right. So how does that impact like the way that you're communicating in that capacity? I mean, when you're really looking at, okay, we're talking to everybody in a group, or even talking around a child about something that's more serious and using different language. I mean, how do you think your communication changes based on A, that dynamic, and B, when the child's present in the room?
Yeah, great questions and great subject for discussion. So there are a lot of different ways to approach this. I don't know that my approach is any better than anybody else's. I think everybody has their own sort of unique way of communicating in the family dynamic. For me, I've made it a policy early on that children should be involved. Now, many kids are too young, of course, to be able to rationally be able to describe their own healthcare concerns or be involved in the decision making. But I still believe that they should have an opportunity to at least be a part of the conversation. So I always make sure, for example, in the course of an office visit, when at the end of the visit, I have a stock line that I say to every family, are there any other questions that you'd like to discuss today? Or is there anything that we haven't talked about today that you'd like to discuss? And when we're done with that, I turn to the child and I say, do you have any questions about anything that we've talked about today? Are there any things that you'd like to talk about today too? And sometimes the kids may have questions. Other times the kids may just want to point out that they see an airplane outside the window. Sometimes they just say, do you have candy or stickers? But whatever it is, I want them to have some input into that conversation. I want them to feel engaged in that process.
Yeah.
Now, again, often they're not going to be able to actually make rational healthcare decisions for themselves, but I want them to feel that this is a part of their process and that things are not just happening to them, they are involved in the process of what goes on to taking care of them. And so that's kind of always been my approach to doing these things, is have the children involved and engaged. Sometimes in very difficult conversations when we're talking about cancer or potentially life-threatening illnesses, if the child's old enough to understand, I will ask the parents and the child if they'd like to be in the room for that conversation. Frequently, the parents will say, no, if you don't mind, I'm going to have them step outside and watch a movie. We have movies playing in our sub-waiting area so the kids can watch films.
Yeah.
So we'll have the child sit and watch a movie while we have a conversation just with the parents. So with each circumstance, you have to kind of be attuned to what exactly is going on in the room. What's the dynamic? Me working at an urban tertiary care center, I can tell you stories for hours about patients I've had where there's a patient, there's a foster mother who's trying to adopt, there's a biological parent who's there who doesn't want the child adopted out, there's a social worker there, there's somebody from CPS there, and you're negotiating amongst 4 or 5 people over this same child who have different interests and different a little bit of a different take on what's going on. And so you have to be very attuned to that dynamic for each individual circumstance.
Yeah.
It starts with simple things. One of the things I've learned since I've been here is that when I walk in the room, I don't assume that the person who's in the room is mom or dad. I will say, hey, I'm Soham Roy, nice to meet you. And you are, and they'll say, oh, I'm mom, or I'm dad, or I'm grandma, or I'm foster parent, or I'm this, that, or the other thing.
Yeah.
And so give them a chance to say, here's who I am and here's how I fit into this role. And I think that helps sort of establish our communication early on into how we want that to look.
Sure. Well, and I think you hit on a couple interesting things. One of which is like really meeting like the child where they're at and saying, okay, like, are you bought into the process? Are you like at least feeling like you have control? I mean, even my kids, I have twin girls that are 2.5, that they're still, even though they wouldn't understand anything, being a part of the piece of like, okay, like, are you good with this? Are we okay? Like even giving shots and stuff is super, super important. And the more that's engaging with them versus just, talking over them. I think that that's interesting even too, when you're talking that why with much, much older geriatric patients, I would think that would sometimes be the same dynamic shift almost, where the kids are still the ones that are taking care of the parent. And you're also want to be like, okay, am I speaking to your level, even though someone else is making that decision? So that's interesting, kind of, just always being aware that they, even though they're not the ones that are making the final decision, they have to be bought on at every piece of it.
Yeah.
Let me ask you this question, because you mentioned something interesting, is how do you kind of work to manage or communicate when, if it's a typical adult patient, they make the final decision on their care. What about when there's multiple people making the decision and they are not seeing eye to eye? You referenced that. Like, how do you go about kind of mediating and communicating the importance of what's happening to help them make almost a decision?
Well, is it too early in the morning to start drinking? Because I feel like I need a drink when we talk about subjects like this. I have horror stories from situations like this. I did want to just go back to one thing you said real quick. You mentioned, even though your daughters are 2.5 and you feel like they don't fully understand, believe me that they do understand some things. They understand the things that are happening to them. They understand pain. They understand fear. They understand trepidation. And so as a father of a daughter who up until about 3 weeks ago had a paralyzing phobia of shots, one of the things that I think you're doing very well is by having that communication early on with children, you're setting them up in the future to understand, hey, these things aren't just happening to me. I'm a part of this decision. I'm a part of how this goes. And I think you're preparing them well by empowering them in the future, even at a young age, to say, hey, I want you to be a part of this conversation.
Right.
So I think that that's very sound thinking, because even if you feel like they're not getting a lot out of it now, you really are setting up a good foundation for them when they're older children, when they're 7 or 8, to understand that, hey, you are a part of this decision-making process.
Right. And you're an active participant in your own health, like throughout this whole part too, you get to decide, you get to help figure it out. yeah, I mean, it does really set that tone even for them to make better decisions
Yeah.
because they're seeing how they're being made.
And so I've always said I think that's very wise decision making. Now, as for your other question, yeah, parents in conflict, and in this era, and particularly living in a large urban environment, I frequently have parents in conflict. And every electronic medical record note I have has a red flag at the top if there's a social situation to be aware of. For example, mom says, "Do not give dad information." Dad says, "Do not allow mom in the office visit." I will redact some information, but there is a child that I saw who I know the father from outside the work arena. And I also know the mother from outside the work arena. They are not together anymore. Mom brought the child in to see me for a problem that I was able to fix relatively quickly.
Sure.
Father has a background in healthcare. He called me up on my cell phone and started screaming at me an hour later, threatening to report me to the medical board because I didn't have his permission. And I said, "Man, I'm really sorry. I certainly don't mean to violate your parental rights, but their mother brought them in and she has the legal right for signature for treatment."
Yeah.
And when I explained all this to her, this is what she wanted to do. And I proceeded. So your problem here isn't really with me, it's with her.
Yeah.
And, that's an ugly dynamic. And it's
Sure.
unfortunately one that we encounter more and more often, which is why the presence of people to help negotiate those sorts of things has been very helpful in our environment with social workers and things like that to help really create a better construct. Because as physicians, I don't want to negotiate difficult family circumstances. That's not what I'm here to do. I'm here to direct my resources and my knowledge base towards making the best medical decisions that you can as a family for your child,
Right.
not for me to negotiate arguments between mom and dad, which they frequently ask me to do.
Yeah, absolutely. Well, and I think also as, COVID has hit and, access to guests is restricted and potentially not everybody is able to come to the visit. I don't know if you have like one parent that's allowed or whatever it is. Even if they're wanting to both participate in that conversation, oftentimes, probably now more especially, they can't. So how do you kind of manage even that communication when you're playing a little bit of game of telephone with that other person or saying this is how you need to explain it to that other person?
Yeah, terrific conversation. So first thing is, the advent of modern technology has been fantastic. So telemedicine has allowed us new opportunities that we didn't have before. Bless you. So we will frequently use telemedicine. Oh, if only I knew a good ear, nose, and throat surgeon to help you with your aspiration.
I know, right?
So frequently we will use telemedicine technology to engage a parent who's not there. Or frequently, if mom's there and says, "Well, dad's at work," and I'll say, "Well, would you like to call him?" And he can listen in on this conversation, and we'll make sure we get his questions as well. Frequently, and this may just be my own bias, but if it's dad at the office visit, we're discussing surgery, I will usually recommend to them, "Hey, before you commit to anything, how about we talk to mom so you don't have to, say something and then deal with this when you get home." It's like, "Yeah, mom's going to have a lot of questions." I'm like, "Great. Well, why don't we get her on the phone and let's talk it through with mom so that her questions are answered."
Yeah.
And so I try to make sure that parents have an opportunity to engage anybody else who might be involved in the decision-making process. Frequently, for example, grandparents will come in if both parents are working. And while they have the authority to bring the child in, they do not have the authority to make medical decisions, for example, for surgery. So I'll give them the whole speech and I'll say, "Would you like to discuss this with your family, or would you like me to call them now to discuss it with them?" So there are a lot of different ways to do that. Certainly, there are some new technology platforms. I know that Medical Memory is a sponsor of this podcast. Medical Memory has a great platform for things like that, where you can record some of your information and patient visits, and so that others can review it and replay it at their convenience, so that they better understand what the nature of the context of conversation was.
Yeah. Well, and I think that's one of the things that we've really started to see evolve as the technology has evolved. Again, it's with an older population is who we've mostly been partnering with, and seeing as access to guests has been restricted and mom's in the hospital and power of attorney is making some of these decisions for somebody that isn't able to be there, having the ability of these doctors to be able to record straight from their mouth information about, hey, here's what we're suggesting, here's what we think, here's what our concerns are, risk, benefits, alternatives, so on and so forth. Allowing right even in front of that patient so they can give their feedback or ask their questions there. It does provide a really solid tool for shared decision making when it comes to everyone else deciding, what's going to happen. I definitely think, especially in pediatrics, this becomes a really impactful resource to be able to utilize too, where, yeah, mom can't come, grandma's at work, or dad's separated, whatever it might be, of saying, hey, let's get people off the phone, calling back, and recording it. So again, it's straight from the doctor's mouth. And I think as access to guests has been restricted, not just medical memory, but a lot more people are aware of the technology that's available, starting to lean into, conference calls, Zoom calls, to keep families connected and provide them the ability, for shared decision making, especially even I think with a kid as much as on the other side, which we see a lot more often.
Yeah, I mean, I think that's very true. We talk about shared decision making. It's a critical part of what we do in pediatric care. The old days of paternalism are gone, long gone, and thankfully gone, because paternalism in medicine, in my opinion, has no place in the modern era. And instead, we want to really rely on shared decision making with parents. In the ENT world, there's been a real well-established person who's considered to be the thought leader in shared decision making for pediatric ENT care. Her name is Emily Voss at Johns Hopkins. She's written a lot about the shared decision making models for parents. And like you mentioned, in the geriatric world, where sometimes you'll have power of attorney, or the parents or the children are taking care of the parents. In the pediatric world, until that child turns 18 or is otherwise legally emancipated by law, your parents make that decision. So if you're 17 years old and 360 days and your parents say you're going to have this procedure done, well, even if you don't really want to, ultimately your parents get to make that decision, or your legal guardians. So shared decision making is critical, both with parents and involving the children as well. But every patient we see in the pediatric arena has that same element of proxy care. It's not just care approved by the patient, but it's by their proxy caregiver.
Right.
And that's true for all of our patients, whereas in geriatrics, it's only some, depending on their ability to make autonomous decisions.
For sure. And I think that's where it becomes even that much more important that not only are you communicating about all of the pieces that are necessary to make that decision, but educating everyone that's really involved too,
Yeah. And, nothing frustrates me more, to be honest, than I will see a child in the office with a parent, or maybe both parents, and we'll have a lengthy discussion about intervention or surgery or something like that. And then we get to the day of the surgery, and I come to the hospital, I say hi, and one parent's there, but she's there with someone else. For example, a grandparent. And I say, I review everything again, and I say, do you have any questions? And all of a sudden the grandparent has 10 questions.
Yeah.
And I'm like, you weren't at the office visit. That's why you have 10 questions, because clearly your child didn't explain this to you about your grandchild. Yeah. And so then I basically have to repeat an office visit in the holding area in surgery. And that gets exhausting, having to, triplicate your work because one person wasn't there at the office visit and they didn't communicate it effectively.
It's so interesting that you even say that, because our surgeons at Barrow Neurological Institute is where medical memory was incubated. And they actually have started implementing that. They rewatch the consultation where they talked about surgery. So a lot of their doctors have been recording visits for 5 years, where they will do the visit. Okay, here I'm going to explain everything. They record it. And so there is this pre-op appointment where they go over all their informed consent videos, pre-op videos, but also while they're in there, they're saying, hey, rewatch this consultation and make sure that there wasn't any questions that you now are thinking of popping up. And then again, the family members have access to that and can share it. But it's interesting because that whole journey is what they're starting to really look at, especially in a spine surgery where someone like my dad had spine surgery. It took him about 2 years to finally commit to it after he had his original consultation.
Sure.
I don't even know.
He doesn't remember anything from the office.
Some of those things where you need to have it done, but it doesn't have to be done like an ER situation. That lapse of like, okay, well, what did they say 4 months ago, 6 months ago about what's needed,
Yeah.
So outside of recording, how do you and sitting with them, in a visit, how do you, educate or how do you battle that kind of challenge, to make sure that they're really understanding everything walking into it?
It is a challenge. And, this gets into the larger issue of informed consent. And we could talk about this as a separate issue. We always talk about informed consent, but the reality is when you look at the data behind it, there is no real such thing as informed consent. most patients don't have the background medical knowledge to really make an informed decision, no matter how much you really discuss it with them. Now, when you're in pediatric care, in particular working in a large urban environment, we frequently have language barriers, educational barriers. A lot of my parents are teenagers who are still in junior high or high school. So, and they're now making decisions for their baby. So, a lot of times we have other barriers rather than just the basics of remembering what was said 4 or 5 months ago.
Yeah.
So essentially, you're frequently repeating the same information on multiple occasions, hoping that, by the third time a parent's heard this speech, it's going to register with them. I'll give you an example. One of the most common surgeries we do as ear, nose, and throat surgeons is taking out somebody's tonsils. And before, in the pre-op visit, we go over some rules with them about not eating anything super sharp or crunchy, limiting their activity to no strenuous activity, what they can do for pain management, what to expect afterwards. We then have that same speech again in the consultation room before we go into surgery at the hospital. So we have that conversation in the pre-op area. And then when I come and see the family again after surgery, 20 minutes later, I again remind them, hey, remember, soft diet, no strenuous activity, go over it again. So they've heard it 3 times.
Yeah.
And you can only pray that by the 3rd time it may have registered to some degree. But, as we discussed, you may have given that speech to one person in the office, to 2 people, or one of the same and one different person in the pre-op holding area, and then to a totally different set of people in the post-op area.
Yeah.
And so you don't really know how much of it sticks. And that does become a concern.
Yeah. So what would you, if you were going to say, okay, like, the 3 things that I make sure to make sure every single time I'm having one of these conversations in hopes that they're really going to understand, or the 3 things that I try to be very, very most aware of as I'm communicating, not necessarily with just a parent, but also with the patient themselves. Let's say it's someone that would understand, like a teenager. What would you say are some of those like things that you're like, every time without question, I always make sure that I do this, and to ensure that they're not only understanding, but they're really like listening and communicating well with me?
So the first thing is, I think active listening is very helpful. So active listening is not just sitting there and listening. It's saying, do you have any questions about this? Do you understand this? Or even asking questions saying, what kind of diet do you think your child should have after surgery, so that they can mirror back what you've already told them. So active listening is key. Reinforcement, I think, is critical, and making sure the parents are engaged. So, I think, like many surgeons, tends to sometimes kind of get into a word salad or a word vomit, where for 10 minutes, you're giving them the speech about the potential risks, benefits, complications, and alternatives of the procedure. And then you're done and you're like, do you have any questions? And they're just looking at you like, because you've just overwhelmed them with a 10-minute monologue using some dialogue they don't necessarily understand.
Sure.
And that's not fair to the parents. It's not on them to have to understand what you're saying. It's on us to make sure that they understand what we're saying, and to putting it into language that makes sense and into terminology that makes sense. So, that's something that I think I strive to really try to do a better job, but I know I still have a lot of work to do on that as well. And so there are those things. And then again, as I mentioned, every patient needs to have an understanding of the reasoning behind the decision-making, not just here's what we're going to do, but here's why this is what we recommend. Okay. And here are your options. Here are your varying alternatives, the pros and cons of each alternative. And finally, most importantly, what questions can we answer for you today?
Yeah.
Okay? We are here to guide you in your healthcare journey. I'm not here. Parents often say, well, what should we do, doctor? And I will tell them every time, I'm not here to tell you what to do.
Yeah.
I am here to give you information. I am here to guide you and to answer questions. You are here to make your best decisions for your child's healthcare. But ultimately, I am here to be your guide, to be your advocate, and to be your source of information. I'm not here to tell you what to do. I'm not here to make decisions for you. I'm just here to guide you and to provide you with information. And so I think it's important to remember what our role is as surgeons in these situations.
Yeah, that's interesting. Well, and I think, and so I guess even too is, when I'm thinking about that type of conversation, or, I mean, luckily, well, I take that back. There was a spine scare with one of my babies. They were fine. But dealing with my child having a health issue versus me having a health issue, I'm like,
totally different.
Tell me what I got to do. Like, listen, like I'm taking notes. I'm like right in there. And I think when I first heard that there might be a surgery that my child needed, who tends to be a very calm, logical, rational person, just got really, really emotional and really scared. And I just couldn't even see straight, let alone, understand what was saying. How do you deal and battle with that, or those conversations, or do you pause the conversation when you're recognizing this is good news, this parent is now potentially emotional, or it's more so than themselves? How does your communication shift there to make sure that we're getting that piece out of it that comes, I think, only with a parent and a child?
Well, it's interesting you would say
with adults,
Well, it's interesting that you would say, how do you change that? Because what I would offer is you shouldn't change it.
Yeah.
Your interaction should all be cognizant of the fact that parents are going to be very emotional about their decisions. You mentioned, with your own daughter and her concerns. The first time my daughter was in the emergency room, I cannot begin to tell you, I wept openly when I found out she was going to be okay. I mean, I just lost my mind when I found out she was going to be okay.
Yeah.
Even remembering it is difficult for me, because even as a parent and as a physician, it is totally different when it's your child, because I'm no longer the physician, I'm the parent. And so I understand the complexity of emotions people go through. And I am always in awe of the resilience of the parents. I take care of a lot of chronically sick children who are tracheostomy dependent, ventilator dependent, have serious neurological concerns and things like that. My daughter's been entirely healthy, thank God, most of her life. But even I lost my mind the first time that she had to go to the emergency room. I was an emotional wreck. And so these parents have such incredible resilience. But yeah, you have to be cognizant of that. I just saw a patient this morning. It's a colleague of mine, their newborn daughter. She's 5 days old. And I saw her for a consultation this morning. And I, immediately want to be attuned to the fact that, the first couple of weeks of a baby's life is a very emotional time for parents. They're exhausted. They haven't slept. They just got out of the hospital. And so as we talked and the baby needed a procedure, I just said to both mom and dad, dad's a colleague of mine and mom I've known for many years. And I said, look, this can be very trying for new parents, and your baby's going to cry. I promise they're going to be okay, but they are going to cry, and that can be hard for parents. Do you want to be in the room while we do this? Would you like to sit outside? What can we do to make this more comfortable for you? And dad said, I want to be here with the baby. I'll hold her. And mom said, I want to go sit outside. I said, okay, we're going to walk you outside and you can watch a movie. I'll come get you in a few minutes. So it's important to always be cognizant that, with parents, it's your child. I mean, there's no greater resource that you have or greater gift that you have. And now you're entrusting them to the care of somebody you maybe met 10 minutes ago. That is a tremendous leap of faith. And I always have to remember that, parents have literally given me the greatest gift of all, is their faith, even in a brief interaction, that I will do everything in my power to take great care of their child. So, I would say that rather than retuning your conversation, if you think the parents are going to get emotional, instead assuming like, hey, this is their kid. This is their most vulnerable time. You have to treat everybody like this is their most vulnerable time period. And I think a lot of that just revolves around emotional intelligence. Now, I say that, and I grant that many people listening to this podcast will say that surgeons are not exactly known for their emotional intelligence. But I would say that that is something that we learn and something that we can acquire, and some people may have inherently more of. But it's an important thing to use in interacting with people in the medical arena. I think that's incumbent on us to be aware of what parents are going through. I will say that, I was a lot more detached about it till I had my own child. My first, I've been in practice 19 years now. And my first 12 years before I had a child, I was pretty clinically detached. Here's the science, here's the data, here's your options and your pros and cons. But now it's like all of those things plus, gosh, I know what it feels like to have a sick child. I know what it's like to be under this kind of stress. How can I help you feel okay about making a decision? What do you need from me that's going to help you? And so I try to bring that into every interaction.
Yeah, that empathy of, like I've been there. Like, what, I know how it feels. I've walked a mile. Like, how do we make sure that you feel comfortable?
But even for people who haven't yet had children, I think, we do need to be aware that this is an emotionally charged time for parents, and to treat every parent like that. The simplest thing, and this is stupid, but the simplest thing is, in every one of my clinic visits, we have a box of Kleenex sitting next to the parent chairs. Just there, it's there. And frequently, if I see a parent getting a little teary-eyed, I just grab the box and I kind of gently hand it to them so they can grab it and keep talking. And they don't interrupt what they're saying. It's just we understand. We're here.
Yeah.
So,
yeah. And then also it's even that physical action is so empathetic. Like it's such a solid, like I care about you without actually saying it. And it also says there's a reason this is here. Most people are feeling really emotional.
Yeah,
Most
absolutely.
people get really upset.
Absolutely.
Like this is what we do. This is how it goes.
Over the years, I've learned a few other important things. Parents really prefer, and patients prefer in general, if you sit down when you talk to them. So if you sit down instead of standing up while you're talking to them, they feel like, hey, you're a partner in this. The other thing is, frequently, the way my rooms are arranged, rather than sitting facing somebody, so we're going like this, I will sit next to them, European style, so we're facing the same way. Yeah. And so I will pull up a chair next to them, and I will turn and look at them, and I might put my hand on their arm, or we'll sit close to one another and talk, so they understand, like, hey, we're aligned in our vision here. We're working together. We're not confronting one another. We are looking the same way, looking forward. Right. So we're working together, and I use that technique a lot with my long-term chronic care patients who I know I'm going to be seeing for the rest of their lives, because I want them to understand, like, look, you have a partner here in this.
Yeah.
And sometimes when all that fails, I will tell you that I'm very direct about it. And so for example, we do a lot of tracheostomies for long-term ventilator management in babies because we have a very high level neonatal ICU population here. Well, eventually, thank God, most of those babies do get discharged from the NICU, and then they come back and follow up with us for their trachs. And if they're still on the ventilator and they're going to have a trach for a long time, I always pull up a chair, I sit down next to the parents, and I say, look, when we were in the hospital and had this conversation around a tracheostomy, it was hectic. You had 100 different people talking to you every day. You were being forced to make decisions and answer questions. And I said, this is our time to take a deep breath and really establish our relationship. And I said, because look, you and I are going to become great friends. We're going to be spending a lot of quality time together over the years. And we're going to become great friends. I'm going to be there every step of the way for you. This is our chance to sit down in a calm, not time pressured environment and let you ask questions and give you an opportunity to discuss whatever's on your mind. Yeah. And so I think that gives them a chance to realize, like, wait a minute, I have an ally here. This is somebody. There's an old statement we used to use at my last institution where we would look at parents and we would sometimes hold their hands and say, I just want you to understand, I'm the best friend you have here because I'm here to advocate for you. I am literally your best friend in this place. And that's what I want to be. That's the role that I want to serve for you. And as long as, sometimes saying that overtly, parents will understand, like, hey, this is a partner in healthcare, not just some guy who's going to come and do a procedure. This is somebody who's in the long haul for us.
Right. That's so beautiful. Well, and that's such like not only just your physical explanation of like what you're doing with your body. We're sitting next to each other. We're looking in the same direction. We're looking very aligned at where we're going to go. But even just taking that breath of saying, hey, let's calm. We're going to be here for a long time. Let's look at this is a partnership. It's not you're the doctor, I'm the patient, or I'm the doctor, you're the patient. It's none of that. It's we're going to be here together and I'm going to be here with you. And it changes that dynamic of, okay, I'm a trusted advisor and mentor here. I'm not just, that white coat syndrome of just taking care of what I need to, I will tell you we're here together.
The greatest part of pediatric care, this is going to sound ridiculous, but you are often invited to kids' graduations from things, elementary school, junior high, high school. You get invited to their birthday parties. You get invited to their recitals. One of the coolest things I ever did is I have a child. He's not a child. Dear God, he's like a grown man now. But I have a patient I've been taking care of since he was probably 9 or 10. Yeah. And he started playing the violin in his school symphony. And I was a professional violinist before I went into medicine. And so for his senior concerto in high school, I played the Bach double concerto in D with him. And he and I played the 2 violin parts together because I'd been with him for like 9 years. And, he's just the coolest guy. He's in college now. But just to be invited to do that, like, that's the coolest part about pediatric care is getting invited to watching your kids' graduations and to, your parents inviting you saying, hey, our daughter's 9. We'd really like you to be there because she wasn't supposed to live this long. Like, that's cool. And that's a good feeling. It makes my job worth it. So.
Oh, man. Well, I cannot believe that. And I think that really shows, how much you care for your patients, how much you're an advocate for their care, communicating with them, educating with them. I love some of the nuggets that you mentioned about not only the physical place of it, making the child be a part of the conversation. I mean, Dr. Roy, you are a wealth of knowledge and intellect, and I so appreciate the time that you took to join us today.
Thank
About
you. I can
how
safely
we
say
can really apply this.
I can safely say nobody in the history of mankind has ever referred to me as a wealth of knowledge and intellect. So I'm very flattered.
Well, you deserve it. Well, I so appreciate your time today. I think you gave us so many awesome nuggets that we can really think about that not only will apply to pediatrics, but even start thinking outside of even just that scope. So thank you so.
I hope so. Thanks so much for having me.
All right. Bye.